Okay, let's get started. So I'm Rob Noecker. I'll be helping to moderate today. We have an excellent panel today, and this is part two, the follow-up on a prior discussion that we had a couple of months ago and is also available online. So this panel is made up of a number of worldwide experts, probably some of the most experienced people with MicroPulse TLT, and that's what we'll be talking about today. Our kind of the force behind this is Tomas Grippo, and also we have a number of different panel members here: Jella Ann, Jacob Brubaker, Richard Akram, Ronald Akram, Brian Francis, Brian Jerkins, Mike Javinga. Nate Radcliffe won't be with us today, but he's contributed significantly, and then Mark Totenberg. So let's just refresh where we are on the MicroPulse TLT consensus panel. And really what the objective has been is to provide guidance around MicroPulse TLT, because even though the technology has been out for a number of years, commercially available, there's been some changes. The biggest change is that the probe has changed. And so what we're talking about now is really kind of an update on how to use the newer system. Also, through clinical research, there's been a number of advances in terms and kind of a coalescence, which we'll see here in the discussion today around the settings. The funding was provided by Iridex, but this is solely clinician run. And basically what all of these recommendations are based on either a Delphi panel, kind of a consensus of clinical experts, or review what the information that's now available in the literature. So once again, how we came to these conclusions and recommendations for the experts, which we saw mentioned here before. And then we looked at the literature, which is actually quite significant at this time around MicroPulse. And then we had several rounds of consensus panel meetings to basically hash out and come to where there was kind of vagueness or somewhat discretion. We came to a best practice or a consensus around it. So part one talked largely about patient selection and dosing, and that webinar was back in November. It's still available online. And that was kind of the preamble to this meeting. This is, I would say, a little bit more advanced in nature. We're getting to some of the more subtleties around anesthesia, what you actually very kind of concrete nuts and bolts, what we do around the therapy, and then talking to more, I guess, more exceptional cases around that involve the treatment of MicroPulse TLT. So we're going to recap the consensus findings from part one, and then we're going to move into addressing all the consensus findings that we have in this part. We'll talk about a few patient presentations, have some discussion. This is a part where the audience can send in questions and be interactive, and then we'll try to wrap it up in about an hour and a half here. Okay, so thank you very much. Once again, I'll show this slide later on. What we're going to do now is I'm going to shift over to Tomas. Do you have your slides up, Tomas? You can share your screen. I'll stop sharing mine. And so there'll always be these little transitions here. If I can stop sharing my screen, that'd be a good thing. There you go. And next we'll hear from Tomas to kind of update us on where we are before we kick off this section.
Great. Thank you so much, Rob. And for the next 7 to 10 minutes, I will be doing a short recap of some of the most important findings or concepts that we learned during the first chapter of this consensus effort. And this is about answering questions that we all have as clinicians. And one of the first questions that we came up with was, does the amount of energy applied have an effect on IOP reduction and duration of effect? And this is a very important question. And even though it may sound like a logical type of answer, the one that I will be telling, when you look at the literature, you can see that, we have all been struggling a lot with defining what the correct amount of energy applied is to achieve a good balance between effects, outcomes, and side effects. And all of these findings are, like Rob said, based on either clinical evidence out there in the literature or a consensus-based Delphi method. So the amount of laser energy applied determines if the effect is achieved and if that effect is reversible or irreversible. Whereas low total energy results in a lack of efficacy and or sustainability over time of the IOP lowering effect, increased total energy is associated with a more permanent effect. And again, even though this may sound totally logical, you may find recent publications in the literature where people have been using very low energy settings and therefore have not obtained the expected results. The second question is there a sweet spot for the parameter used in MicroPulse TLT to achieve a good efficacy while maintaining a good safety profile? And it appears that there is one. When we actually use very low settings, we may not obtain pressure reduction or enough pressure reduction. And usually we also see a pretty good safety profile. If we use just an excess of energy, we may encounter a higher prevalence of side effects. So there is this sweet spot that we've been trying to determine over time, and we're getting closer and closer as more evidence builds up, where we can have good results with a very good safety profile too. And when it comes to the old literature, what do I mean by old? I mean, with the literature, when we use the original probe, we saw that there was this sweet range of energy that would go between 150 to 200 joules of total energy. And at that point in time, what we were doing is 10-second sweeps per hemisphere. This sweep velocity has actually changed as we realized the importance it had. So this gives us an idea of what were appropriate energy levels to obtain good results in the past. And it also is a foundation for what we are doing with the new probe. And one of the other things that we learned is the importance of sweep velocity. And just to reinforce this concept, up to 2021, only 14% of the literature of the papers that were published described sweep velocity in their publications. That means that not only did the researchers not find that such an important variable, but it also means that in clinical practice, when we were performing our MicroPulse TLT procedures, we were not really paying so much attention to how fast we were going. And the fact is that that has a big impact on energy buildup on the target tissues. Therefore, we came up with this suggestion that fluence may actually be a better representation of the dose of energy that we are applying per square centimeter to the eye. And fluence actually, when you calculate fluence, the equation keeps it in mind, includes sweep velocity as a variable. And sweep velocity combined, fluence combined with total treatment time gives us probably the best representation of the amount of energy that we are providing to the eye. And we can think about this as fluence being the dose of energy that we are applying, the intensity per square centimeter, and total treatment time, the dosage, the frequency to which we are applying that dose. In the prior literature, the energy settings that were usually described was of total energy was 62 to 200 joules with a mean of 112 joules, a fluence value with a mean of about 55, and a treatment duration per hemisphere that ranged between 50 and 160 with a mean of about 90 seconds per hemisphere. And as I mentioned before, the most frequently used sweep velocity was about 10 seconds. In general, when you looked at those settings, when people used those settings, they were obtaining a pretty reasonable pressure reduction that may have been around like 30% with a pretty good safety profile. Now, having reviewed all of this, and with the fact that there is a new probe in the market that does have significant, that does provide significant improvements on the safety profile and maybe also on the efficiency and outcomes that we get, we as a consensus panel came up with a suggestion of parameters that should be a starting point when we treat our patients with MicroPulse, which was as follows: 2.5 watts of energy, duty cycle as usual of 31.3%, and 4 sweeps of 20 seconds each per hemisphere. And we believe that these parameters can be used as a starting point in the majority of our cases, unless there is a compelling reason to adjust the energy delivery up or down. And today we will be discussing when we think that we should be going up on our settings and how we should approach that. And it's clear that there is not enough evidence or experience yet to provide definitive minimum and maximum settings, as there is too much variation in patient characteristics and clinical scenarios. And we're actually learning a lot as time goes by. And today we will be presenting a few clinical cases where we will be discussing how to increase the amount of energy delivered. Now, when we go up on our settings, we suggest to go up about a 30%, 20 to 25%, 30% in energy delivery. And this can be achieved by different ways. One option is to increase the power. Another option is to decrease the sweep velocity. And another option is to increase the number of sweeps that we do per procedure. And another concept that it's important to highlight is that we believe that although we understand at this point that there is what the lower limits of energy are to obtain an effect, we acknowledge that we still don't know exactly the upper limits of energy that we can apply to the eye. And at this point, we are exploring that. And most likely in the next, in the near future, we will be able to determine that with more certainty. We believe that this consent process has helped us also define how we want to approach that in a mostly as safer as possible way. So thank you, Rob.
So thank you. So just stop sharing your screen and we'll get Mark up and ready. As soon as he's sharing his screen, we'll get him going for the next part. But let me ask you, Tomas, what got you to think about fluence in the setting of MicroPulse? You kind of changed their thinking in a lot of ways that we should pay attention to this.
Well, this could be a long answer, but
have the short answer. Let's go for the short one, okay?
Let's go for the short one. As we started to understand better the implications of the different variables that we're applying on our patients, and we still saw that the results were somewhat heterogeneous, even though, when we determined the sweet spot that I described earlier, the results became a little bit more consistent. We realized that there was something else out there that we were not keeping in mind as much. And the fact is that, the MicroPulse TLT inherited a lot of, came from the continuous wave cyclophotocoagulation of the continuous wave technique. And there are several differences, significant difference that we didn't realize at the very beginning between these two techniques. Of course, the MicroPulse mode, which made a huge difference, right? I mean, the fact that the MicroPulse actually, divides the laser in off periods and on periods, but also from a technical standpoint, we are not doing discrete spots with the traditional MicroPulse technique nowadays, as we used to do with the conventional cyclophotocoagulation. And when you are moving when you're sweeping around the eye and you're moving the probe, you have to keep that in mind to be able to calculate the amount of energy that you're delivering. And fluence, you know, it's a term that comes from physics and so on, much better incorporated that variable that we were neglecting to some extent. And when we reviewed the literature and calculated fluence and total energy for the different studies where we did have the information, we saw that there was a better relationship between fluence and pressure reduction compared to total energy. And that's long story, sorry, Rob, about how we came up with this.
So you gave us the long answer, but thank you very much, Dr. Verpo. All right, Mark, you ready?
Yeah, I am. Hi, everybody. Hi. So Thomas said, like, we want to go a little bit more practical today compared to the first webinar. And the first thing we talked about in this process is what is the preferred treatment environment for MicroPulse TLT? So how do we feel comfortable when we want to perform MicroPulse TLT? And in general, it is possible to perform MicroPulse TLT in an office setting, but most of us feel more comfortable, and also the patients, if we perform it in an operating theater. And when we think about that, in general, it is possible to perform MicroPulse TLT just under topical anesthesia, but most surgeons prefer topical anesthesia plus sedation. And if you do plus sedation, you need monitored anesthesia care, which is also a supportive reason why the OR setting is most preferable setting. The second question we talked about is what is the preferred anesthesia method? And because they're kind of connected to the first question, I answered that already a little bit. Most preferred technique for anesthesia is topical anesthesia, so drops and sedation. There are general situations when a block may be needed, and that should be left to the discretion of the clinician. And in general, it is possible to perform MicroPulse TLT in conscious sedation because post-op pain is usually very minimal. And to think about a couple of questions that supporting these answers is, you still target ciliary body, and there may be some induced ciliary muscle spasms, which can cause some uncomfortable feelings and some pain for the patient. So sufficient pain control during the procedure is necessary, as well to maintain the patient comfort, but also to enable for the clinician a precise and correct delivery of the treatment. So the location should be precise, and you want to do your sweep motion with a constant speed and at a constant correct positioning of the probe in regard to the limbus. There is no randomized controlled trial that compared different forms of anesthesia at the moment, at least to my knowledge. And especially if you look in literature, we're looking into pain after the procedure, there's a lack of studies doing that with analog pain scales, like with an objective measurement of how much pain the patient has experienced. And quality of life is also something for studies which wasn't looked into when it comes to pain, discomfort for the patient during and especially after the procedure. The majority of the published literature used subtenons, peribulbar, retrobulbar blocks as a method of anesthesia, but there are also studies reporting just using topical anesthesia. If it comes to treating children with MicroPulse TLT, general anesthesia is what in the public literature was most often, or basically in all studies, used, and also in some studies of adult, wherein MicroPulse TLT was performed, general anesthesia was used. No complications due to anesthesia were reported so far. And a decision about whether to use a topical or a block anesthesia should be made based on the anxiety level and general pain tolerance of the patient. For children, coming back to that topic, due to the limited cooperation of children, general anesthesia is the recommended anesthesia form in all cases when performing MicroPulse TLT. Yeah, that's from my side.
Good, excellent. So our next speaker, so we'll just change screens, stop sharing screens, and have Mike Javingo up next. And while Mike's getting ready, so Mark, what do you ask the anesthesiologist to give? Do you have anything specific you give, like Versed or Propofol or both, or what's the most common thing?
So actually, my anesthesiologist usually just use a little bit of fentanyl because it keeps the patient awake, keeps them controlled from the pain level side, but also slows down a little bit to the anxiety level that the patient maybe has experienced before. And you can dose that pretty quickly, like If you inject it, it takes less than a minute until you have the effect, because it has to come centrally to have its effect. And in general, I talk to the anesthesiologist not to use the full dose in the beginning, but to slowly titrate and see what the patient's anxiety level and the nervous level of the patient is.
Okay.
And it also has the advantage that the patient later on is like pretty fast recovered.
Mm-hmm. That's excellent. Mike, you ready?
Yep. Can you hear me?
How are you?
Yeah, great. Thanks for having me, and thank you for everyone attending. So we're going to get into a little bit of the nuts and bolts of actually performing the procedure. So what are the best practices when performing MicroPulse TLT? Why are you not? So one of the big things that I saw, and initially a lot of people were not using, I truly believe that a coupling agent is absolutely necessary when we're doing the procedure, and there's a decent amount of data to support that. Most common among members was lidocaine gel. The coupling agent is generally applied at the very beginning of the case and the probe footplate before the start of the procedure, and is likely reapplied as needed during the procedure. Most of the panelists, again, used lidocaine gel. It was, I believe, around 50-50 whether or not reapplications were needed, but everyone was in agreement that if they saw the eye drying out during the case, a reapplication was done. This is our data. There's other data available looking at different coupling agents. And the one big thing, so we looked at a bunch of different factors trying to figure out what the actual output with a laser meter, just to see how many milliwatts is being produced by or received by the laser. We looked at non-contact 45-degree probe angle and 90-degree probe angle, most of which has kind of become irrelevant due to the new probe in forcing the clinician to hold it at the proper angle. So what we're looking at is the bottom row, the 90-degree probe angle. And with air as a coupling agent, there was a significant drop in the power. So these are all in milliwatts. So just as a reference point, this was done with 2000 milliwatts at the 31.3% duty cycle. So 626 should be full output of the laser. And balanced saline solution, artificial tears, tetracaine, lubricating ointment, lidocaine gel, all were basically equal. And I understand that, air is not exactly normal. There is no air, but generally patients that are chronically on drops, they have severe dry eye, meibomian gland dysfunction. There's a lot of abnormal conjunctival situations going on, loss of goblet cells, et cetera. So somewhere in between that 358 and the 600 level is where you're going to be getting as far as a power output, if you're not using a coupling agent. So I highly suggest using that. Secondly, we looked at exposure of eye. The use of an eyelid speculum is surgeon preference. Items used to manipulate the globe to facilitate exposure are also up to the physician's preference. It is acceptable to either use or not use these devices. Examples are Q-tips, muscle hooks, indentation instruments. I personally, and we can see right here, this is me performing one with a resident of mine. I personally like using the lid speculum. I haven't had any issues with it, no postoperative ptosis, because you, with the new probe, really truly don't have to wrench the eye open as much as previous or with other procedures such as a tube or a trab. And I get a good amount of exposure. I do like having a wet Q-tip just to kind of hold the eye in position. But again, that's surgeon preference, and I see no issue with or without. And there were several participants that did not use lid speculums. Finally, on this section is probe placement. This consensus panel places the anterior aspect of the probe, so the bunny ears on the front of the probe, from 0 millimeters being right at the limbus to 1 millimeter posterior to the limbus. When in doubt, at a location of the ciliary body, such as in very high myopes or hyperopes, transillumination, or UBM, can be used to adjust probe positioning. Again, this was one that there was no complete agreement, other than it works between both 0 and 1 millimeter. Some of which may explain that are, again, I know in the past I've talked about Dr. Johnstone's work several times, but I do think it's extremely important when discussing this. may have to do with the ciliary body destruction, but more so that it works in both positions because there is some ciliary body rotation and increasing of the outflow facility or outflow through conventional outflow. So the placement between those two positions doesn't really matter. And what I would suggest to those watching is go with what you're comfortable with. And if you are getting any issues with corneal haze or any other corneal issues, edema, et cetera, you're treating too anteriorly. Go a little bit more posterior from what you're doing. And I believe that's that on this section. I'll be coming back to talk to you again in a little bit.
Thanks, Mike. So we'll have Jella Ann up next, and we'll share her screen. And so let me ask you, Mike, what's your favorite coupling agent, and has it changed?
So when we did the study, it was actually started because my one partner and I had an argument about whether lidocaine gel, or I was at the time actually just reapplying balanced saline solution frequently, and I had the belief that the lidocaine gel would actually inhibit some of the output. So it was kind of more of an argument than anything else. And sure enough, he was right, I was wrong. So I've gone over to lidocaine gel just because that's what we have in the OR. I'm doing cataracts, doing, et cetera, et cetera. We have it just available. It's sitting there. And then with any of the thinner solutions, I wouldn't suggest reapplying tetracaine a million times during the case because of the cornea. But if you're doing balanced saline solution, which I think is fine, you have to just keep reapplying it. So lidocaine gel is cheap. It's available, and 1 to 2 applications usually gets the job done.
That's great. Thanks, Mike. Yep. Jella, you ready? How are you? You got to unmute you, Jella.
Sorry about that. Here.
How are you?
Hi, everyone. Doing good. So thanks, everyone. So, as, everyone talked about, the MicroPulse is really significantly safer than traditional CPC, but, only with the proper technique and adequate dosage. Those two are really paramount for this technology to be effective and free of any complication. But unfortunately, existing literature is really limited in this regard due to variability of surgeon techniques and variable dosage that they use, and often not consistently reported. So this is where the Delphi panel methodology was critical in identifying the best techniques and ideal settings that we've all honed through years of experience, trials and errors, and continuous outcome analysis of our own techniques and outcomes to improve our results. So for my part, I'll just really go for the basic techniques, just following what Mike just talked about. Once the probe is appropriately placed right at the limbus or 1 millimeter posterior to the limbus, it's really important to apply moderate pressure evenly across the foot plate with a slight posterior bias where the laser probe is located. So that actual laser probe is actually 3 millimeter from the bunny ear, where you will actually align with the limbus. And you want to gently compress the conjunctiva as you sweep across to obtain the optimal laser transmission. It's kind of like a pen to paper. And I do also hold it like a pen when I do the procedure. Applying adequate coupling gel is also important, as we just talked about. In terms of a sweeping technique, most of our members, the consensus members, sweep the probe per hemisphere, spending 20 seconds per sweep from nasal to temporal, sparing 3 and 9 o'clock, then reversing the direction from temporal to nasal over another 20 seconds. So I'll show you the video of doing that. It's quite slow, but you want to be constantly moving, but you do want to spend the full 20 seconds going from nasal to temporal. After completing 4 sweeps, so that's 80 seconds per hemisphere, you want to continue on the other side, the superior side. Some surgeons do prefer to use a quadrant approach, and that is perfectly fine. In that case, you'll be spending 10 seconds per quadrant, going from nasal to inferior, for example, and then inferior to nasal, another 10 seconds, and then do that 4 times for the total 40 seconds, and then repeat that in the other 3 quadrants, again, for the total of 160 seconds per eye. And that is a recommended dosage treatment time from our consensus panel. It is acceptable to stop and restart during the treatment cycle if it's necessary to reposition the probe, because we felt that the proper positioning of the probe is much more important than adequate, possibly losing the heat because of the stopping the technique. You want to make sure the edge of the probe, the bunny ear, is always at or slightly behind the limbus at all time, and the posterior part firmly pressed under the down to the sclera. So yes, do spare 3 and 9 o'clock as we normally do for the traditional CPC to avoid the ciliary bundles. It's also important to avoid any localized areas of a scleral thinning as shown here, either as a result of inflammatory process or previous trauma. If it is due to inflammatory process that's underlying, such as scleral, the rheumatoid arthritis or scleritis, you might want to reconsider doing the MicroPulse or any kind of inflammatory laser in those settings, or significantly reducing the energy for these patients. Okay, so that's all I have here. So I'll stop sharing.
Great. Thank you, Jella. We'll get it ready for Brian Jerkins. So how did you change your sweep speed? How fast or slow were you going before?
So with the original probe, I was going 10 seconds per hemisphere, as most people did with the original probe. And I also use a very, very low energy. And that slowly became evident that there was much more room for me to increase energy, and increasing the sweep speed or decreasing the sweep speed, going slower, actually made a significant difference in getting more IOP lowering, medication lowering, and also reducing the need for retreatment.
Mm-hmm. Yeah, I think that's very consistent with probably all of our experiences. Brian, you ready? How are things in Tennessee?
Things are good. I'm absolutely ready.
Let's do it.
Just picking up right where we left off, looking at some of the specific cases where you want to be cautious and maybe change your technique slightly. Just like with scleral thinning, when you have very fragile tissue, whether we've all worked on patients who have very thin avascular blebs, it's very important you want to avoid treating over a very thin bleb, as well as over a very thin area of a previous glaucoma drainage device. However, if those areas have completely fibrosed or scarred down, it looks like normal healthy tissue. It is safe to treat with MicroPulse over those areas. What about with our patients with scattered melanin or racial melanosis? In the experience of this panel, this presence of scattered surface melanin does not make a difference in the treatment of the efficacy and the safety with the current recommendations. You can use the normal settings that we would recommend. On a separate note, patients with hemorrhages that are present, it's our panel's belief that scattered hemorrhages, it is safe to treat, but you want to avoid treating over a very dense subconjunctival heme due to the risk of increased energy uptake. So avoid those patients with the dense hemorrhage. If you're considering combining this with another procedure, it might be very important to maybe consider doing this before that part of the procedure if it is going to have a risk of causing some hemorrhage. If there is an area on the eye, say with thin bleb or a scleromalacia that you do need to avoid, if you skip that area, you can still use the total amount of sweep time, just divide that over the remaining smaller area of the tissue. To decrease that risk of bleeding in a patient, so you have a patient with a very red eye, topical vasoconstrictors, whether it be aproclonidine or your drug of choice, is always available. And this will decrease the risk of hemorrhage as well as minimizing the absorption to those superficial vessels if the patient is a very vascular or irritated patient, which is very common on some of our glaucoma medications. That patient with the very red eye, the very same way, very angry glaucoma patient, vasoconstrictors in pre-op as part of your pre-op routine will deem that patient very much an appropriate candidate for this procedure. And I believe that is my section here, and I will come back to talk about another part later. Thank you.
What do you, have you, just in the real world, have you ever had somebody who had like so much pigment on their eye or so much hemorrhage going in that you just didn't do it, or what'd you do?
I have had one before with melanin that I've not run into that, but I have had a patient that I tried to combine with an Ahmed valve one time and tried to do it after the surgery and had just too much hemorrhage from a neovascular type of patient to do it. So that was the one scenario where it has posed a problem before.
But usually you just, if it's a little bit, you just go through it, right?
If it's a little bit and it's not that dense hemorrhage, you can avoid it.
Yeah. Good. Well, thank you. Brian Francis, you ready?
So the first question we were answering in my section is the use of, oops, let me go back. Let me go back to the A. There we go. Is the use of a post-op cycloplegic drop. So many are used to using, atropine or other cycloplegic after ciliary body ablative procedures. But we found that it's really not necessary with MicroPulse. There is no, trials comparing the use of a cycloplegic versus not. But in all the publications basically that reported what their postoperative medications were, none of them used cycloplegic drops. And I think that's kind of also a consensus of the panel that it's really not necessary. So we've determined that. The next question is patients experiencing postoperative pain, and they can be given an oral NSAID, acetaminophen, or opioids for more severe pain. For the exceptional patient who has greater pain sensitivity, providing IV pain medication during and possibly just after the procedure in recovery is a possibility. Supporting evidence, this is really based on expert opinion. There really was nothing in the literature about the treatment for immediate postoperative pain. Many studies did use subconjunctival steroids for control of longer post-op inflammation and pain control. I found in my practice generally, so I'm doing the basically monitored anesthesia care with IV sedation with propofol during the procedure. We typically will bring the patient to recovery and assess their pain there. And we can give them, it can be across the board. So patients sometimes require nothing. Some patients require, Tylenol, oral Tylenol. Some require actually IV or oral Toradol, sometimes helps quite a bit. And then for those with more severe pain, which is a minority, we can give them an opioid such as an oral pain medication, Vicodin or something of that nature in recovery. I have found, and I think most of the panelists found, that even those patients with severe pain right after surgery, once they get through that and they've gone home, they really don't have much in the way of pain. So, all right. So the next thing is about the use of topical Nsaids and or steroids. The panel recommends that you do use topical Nsaids and or steroids ranging anywhere from 1 to 4 weeks for routine cases. My personal routine is to use them for 2 to 3 weeks in routine cases, unless the patient has continued inflammation. The supporting evidence is all the studies recommend the use of topical steroids for a varying amount of time. And then most studies do report the use of a topical or oral NSAID to help with inflammation and pain control. And again, as I said, pain control is usually not an issue. It's just a little bit of inflammation. But I've found personally that you can taper the dose as quickly as we're used to, say, for routine cataract surgery. It's not a prolonged dose that you might see in the ECP or the continuous wave diode CPC. Antibiotics, typically they're not recommended because it's an incisionless procedure. We typically do not use topical antibiotics either pre or post. However, there is one case in the literature of endophthalmitis following the procedure, and that was in a patient with a Boston K-Pro. So if a patient's at a high risk due to infection, either due to corneal abrasion during the procedure or their other disease process, such as having a capro, then we recommend topical antibiotics, for 1 week, as you would do for routine cataract surgery. Several studies did use topical antibiotics postoperatively, but that was as a combination therapy with a steroid. So it was not a separate antibiotic. And then postoperative care, we found that most patients, the most common post-op visit is at 1 week, and then at 1 month, and then tapering after that. Sooner follow-up may be justified based on the individual patient characteristics. What does that mean? It means that if you have someone that has 0.95 cup, very advanced glaucoma with high IOP that you think is one that's at high risk, if they do have an IOP spike, then we'll typically see them 1 day postoperatively. If it's a routine, kind of mild or moderate patient, then we'll typically see them at 1 week rather than at 1 day. Following that, the studies reported follow-up usually at 1 day or 1 week, as we said, and then 1 month, 3 months, and 6 months after surgery. As far as tapering medications, with the exception of Diamox or other oral CAI, which can be discontinued right after treatment based on the individual patient scenario. Again, if it's someone that has very advanced disease, I typically keep them on the oral CAI until the 1 day or 1 week post-op visit. But other than that, topical medications are usually maintained until the response to MicroPulse TLT permits the tapering medications. And the typical full effect is usually seen at 1 month. And the supporting evidence is the majority of studies that did report glaucoma medication use after surgery, they all maintained the preoperative medications and tapered as able according to IOP response. And then here's other references that we discussed in the previous slides.
Thank you, Brian.
Okay,
so,
thank you.
So we'll just have Tomas is going to present next, so we'll have him get ready to share his screen. So do you have any predictors? Do you have any idea like who's going to have pain like with this procedure? Because I think most of us agree it's, post-op is really not much usually, but there are some people. Do you have any feel for, or are you good at predicting who might have pain post-operatively?
Not really. I mean, there are some patients that just have low threshold for pain, so you can kind of predict that they, may have pain. Other than that, I haven't seen a clear difference based on energy levels or, affluence. We've treated some patients very aggressively and they've had no pain, and we've treated patients, with a mild energy settings and they have pain. So it's not that predictable. I don't know what the rest of the panel.
I think that's our experience, but we'll come back around. We're going to open up for questions in a little bit. So yeah.
Okay.
That was very good. Thank you, Brian.
Thanks.
You ready, Tomas?
Yes, I'm ready. So we were talking about the initial settings, the consensus-based recommended settings that we would do on most of our cases. But the question then arises on which patients should we actually use higher settings. And even though the evidence at the very beginning wasn't that clear, there is more and more evidence showing up that may point to specific scenarios. And one of those scenarios is like, should we treat people with more severe disease more aggressively? And there is actually not clear evidence to suggest a change to settings based on disease severity. But most of us would consider increasing our settings up to 25%. And again, that can be achieved by increasing either the power that we use or the number of sweeps or decreasing the sweep velocity. And one example, I mean, in some of my cases, what I would do is, the consensus settings are 2.5 watts, 20-second sweeps, and 4 sweeps per hemisphere. Well, in a case where I would like to go a little bit higher, I would actually do 5 sweeps of 20 seconds per hemisphere as a next step. Some of my colleagues may even consider, if they want to be even a little bit more aggressive, they would decrease the sweep velocity and would go from 20 seconds to 30 seconds and do 3 sweeps of 30 seconds. So that would be like 90 seconds per hemisphere. But we will present some cases later on just to point at this more specifically. Another scenario would be patients, even though there is no clear evidence that we should treat people with different glaucomas differently. One that actually pops up all the time is neovascular glaucoma, which we know is one of those challenging glaucomas with poor prognosis. Well, when there are no valves placed, we think that we should actually treat them with higher settings. And of course, within the neovascular glaucoma spectrum, you have like different stages. But we'll discuss that a little bit later. But the consensus is that we would treat those patients in general with higher settings. So what happens in those patients that have a very high intraocular pressure? And there is actually clinical evidence that pointed out at higher baseline pressure as being a risk factor for a higher prevalence of retreatment. So treating someone with high baseline pressure with highest settings is something totally reasonable and totally reasonable. Now, in patients who are already maximized on maximal medical therapy and have a pressure that is also over target, you should also consider starting with higher settings from the one recommended by the panel. Lens status, on the other side, does not affect intraocular pressure reduction following MicroPulse TLT. So lens status is really not a variable that would, change the way we treat. Thanks, Rob.
Thanks, Tomas. And so we'll get back to Mike Javingo if he'll share his screen. So what do you do if in these cases where you just want to, you think you need a little bit more than just this kind of the starting recommended settings? Well, which parameter do you concretely raise, or multiple parameters?
Yeah, I mean, if I want to go just a little bit higher and just be a little bit more, apply a little bit more energy, I would just do an extra sweep. So instead of doing 4 sweeps of 20 seconds per hemi field, I would actually do 5, so 100 seconds per hemisphere.
Okay.
And if in a case where I really feel that I have to make a difference by increasing the settings pretty much, I would decrease my sweep velocity from 20 seconds to 30 seconds. And I would do 3 sweeps. And that would be mainly it at this point. I think, again, we know what the low settings are that don't work. We know what the standard starting settings should be. And we are slowly exploring the higher settings. And we have some boundaries that are described in the literature, but that was actually described with the old probe, which it's the consensus of this group that the new probe has a better safety profile. So I think the upper limit we will define, in the near short future.
So the short answer was that you'd increase total treatment time and then secondarily slow down sweep speed, right?
Yeah.
Mike Javingo, you ready?
Yep.
All right.
Okay. So what are the anticipated clinical outcomes? So with these settings, what are we seeing as far as our pressure reduction? Lovely. Okay. Overall, the research clearly indicates that increasing power, treatment time, and slowing sweep velocity improve outcomes in terms of pressure lowering as a percent of the baseline IOP. Some studies show a modest decrease in medication burden, but many other studies show no reduction at all, possibly because medication reduction was not the goal. At the recommended doses, the clinician can expect pressure lowering in the range of 25 to 35%. There is limited information to date on the effect of the revised MicroPulse P3 probe and sweep velocity. So this was a difficult question to answer, considering the paucity of studies that are currently available with the current probe. This was our overall agreement, and there is much more to follow as far as our research and combining things, and we will follow up on this. But as far as additional research, there we go, is needed and will help optimize future outcomes. But this is a general overview of some of the more important research that's available. One of the big ones being Sarafpour et al., looking at increasing power. As Tomas indicated earlier, which is very true, a lot of the data that's available just does not have much information on the terms of sweep velocity. And we do know that that's a factor. So if we have multiple physicians performing it, one goes a little faster than the other, nobody's really paying attention exactly to how fast they're sweeping. That data may or may not be relevant. And as you can see, in a lot of the older stuff, the sweep velocity was a little bit lower, up to the 12 and a half seconds per sweep range, which we're more recommending about 20. The overall data is somewhere between roughly 30 and 50%, but we are kind of, as a group, seeing a little bit more conservative in the 25 to 35% range. But again, there will be more coming out from us down the road as far as our own personal data and analyzing this to see where you should expect your patients to get a pressure lowering based upon these settings. So,
good. Thank you. And next up, we'll have Brian Jerkins, if you share your screen. So, what have you changed, Mike, in what you've done recently?
I've the overall settings, I'm starting off with 2,500 milliwatts on every single patient. Very, very conscientious about doing the 20-second sweep velocity. I think is extremely important. And now, as we'll see in the one case I'm about to present, sometimes bumping up a single parameter on a first case, even if I have a patient who we were talking about it earlier. I'm not even sure who said it, but bumping up just on based upon a patient being extremely end stage. So the comfort level with this, that the current settings that we're recommending are extremely safe, and going a little bit higher than that is more than likely just perfectly fine and safe for the patient, even with good central vision.
Good. Brian, you ready?
I'm ready. Continuing on, looking at what are the actual side effects of MicroPulse and most importantly, the new probe here. And it's our belief, we consider this an extremely safe alternative compared to traditional continuous wave cyclophotocoagulation. And I hope we've shown some of the subtle differences between the first panel and also this panel discussion. Many of the complications that we find in the literature aren't necessarily with the new probe, and that can be contributed to previous types of CPC, where there was an excess amount of energy applied. The surgical technique and also the probe design was much different than the current probe. As we're learning more about the understanding of the dosimetry and some of the energy limits that we need to deliver in certain areas, the revised probe allows for a much safer delivery and controlled delivery of those photons in a posterior treatment, which is what we've been talking about on delivery to this point. So many of the side effects that we're used to seeing with traditional CPC and even the original MicroPulse probe have definitely been prevented and minimized. What this translates to our patients is a very safe treatment option for them. So we're getting very fewer events of mydriasis, loss of accommodation, cataract formation, dry eye, and just general side effects in overall for our patients.
Good. Thank you. So next up, we'll share screen with Ronald Crom. And let me ask you, Brian, did you ever see mydriasis with the older probe in your hands?
That's the one side effect that I've never been able to say I've truly seen in my patients. It's always been described, and I probably underappreciated it. With traditional CPC, yes, I do remember seeing that in the past, but not with the original probe.
You ever see it with the new probe?
With the new probe, no. I'm amazed 90% of my patients get in the recovery room and ask when we're getting started. And the side effects, it's just a smooth post-op course for them.
Excellent. Good. All right. You ready, Dr. Crom?
Yes, thank you, Rob. I want to discuss something about the retreatment and enhancement in the MicroPulse TLT. And at first, I want to start with the definitions of these two. So enhancement applies when pressure reduction was obtained in the primary treatment, and treatment is necessary and repeated to obtain an additional IOP reduction. And if we speak about a retreatment applies when pressure reduction was not obtained with the prior treatment, and treatment is repeated with the same settings or higher settings, aiming for an IOP reduction. Earlier in this webinar, it was already discussed that a lower amount of energy used and a higher baseline intraocular pressure show a higher likelihood of need for retreatment. At the other side, we already know that lens status doesn't affect the likelihood of need for retreatment, and also prior glaucoma surgery does not. Glaucoma type is always a little bit difficult to say. Already Tom told us a little bit about it. We know that the glaucoma type as a variable remains unclear if it gives a higher retreatment rate or not. But neovascular glaucoma is a little bit more hard to treat. In regards to the settings which are already described in the different studies, we know if we in the studies which have retreatments has been performed, if we look at the laser power and the treatment time, several studies used the same power and the same treatment time during a retreatment, but also several studies increased the total power, but not the time in subsequent retreatment. In our own study, we increased the treatment power during a retreatment session, and also again increased the power a little bit more up with subsequent sessions of retreatments. Both were performed with the original probe. Already sweep velocity is a very important factor in the treatment of glaucoma, and Thomas already discussed the importance of sweep velocity, and we know that decreasing the sweep velocity from 10 to 20 seconds per sweep gives an increase of fluence by 100%. So if we look at the escalation of the MicroPulse treatment, it seems reasonable that increasing the power or increasing the total treatment time or decreasing the sweep velocity during a retreatment session should be considered. And for retreatments, this panel recommends waiting 1 to 3 months after the primary treatment, depending on the patient case. And most surgeons would consider retreatment or enhancements in most scenarios of variable pressure reduction or sustainability, assuming no complications occurred during the first treatment. And when performing a retreatment or enhancement, some of us will increase some of the parameters, and then you can think about 25% increasing total treatment time. For example, add an extra sweep, increasing the total energy you want to deliver in the eye, while other panel members will maintain the original parameters. And to make it a little bit more clinical, I want to discuss some clinical scenarios. So when you treated a patient, and a patient does not have an initial satisfactory response within 3 months after the primary treatment, some of us would consider to do a retreatment in these patients. Then you can use higher settings. Other would move on to a different procedure. It depends a lot on the patient you want to treat. If you have a patient with a very high intraocular pressure, or patients with a higher rate of progression, you could move on to a different glaucoma procedure. Otherwise, you can certainly do a retreatment in this patient category. Otherwise, if you have a patient who has an initial satisfactory response to your treatment, but your target intraocular pressure has not been reached, then you can also repeat your MicroPulse treatment, and then you can increase also the laser energy delivery. And most of the time, retreatment is done 3 months or more after the initial treatment. You can also have a patient who has an initial very good response with the primary treatment, but it loses efficiency at 12 months or further. In this type of patient, retreatment can be done with or without 25% increase of laser energy. It also depends on the primary effect of your treatment. If you have a patient with a very, very good effect, you can use the same amount of power, the same amount of sweeps if you perform a retreatment. If you want some more medication reduction or some more intraocular pressure reduction, then you can increase the energy. And if you look at enhancement in some patients, there are also patients who have a good response to your treatment, but you want a better response or more intraocular pressure or more medication reduction. In this patients, MicroPulse TLT can be used as an enhancement procedure. And most of the time also here, you have to wait 1 to 3 months after the primary procedure if optimal intraocular pressure is not obtained with the initial treatment.
So Ronald, what do you differentiate between those patients where you had like early success and it faded versus, you know, patients that lasted for 2 years? Does it change like your intent to retreat or your willingness to retreat? Do you differentiate between those patients, or once you start?
In patients which already shown a very good response, a retreatment can certainly be done. And I also have some patients in which I performed the primary treatment already 4 or 5 years ago, and they received 2 retreatments in the last 5 years. So if they had a very good response and it lasted for 2 years, for example, you have a very good reason to do a retreatment in those patients category. Yeah, I agree.
Good. All right, Jacob, you ready?
Yeah, thanks. Sorry, I was a little finishing up another meeting. So thanks for, I think I got here just in time. So that was perfect.
You did. We've been waiting for you.
Well, thanks. So I think this is it's just one slide. So it's like a little blip of Brubaker that you're going to get here, and then that's it. But I think this is really crucial that we have a common language as we are, discussing what is happening with these patients. So, and this is, I think, as we're discussing amongst ourselves, but then more importantly, I think from a research standpoint. I recognized as I was looking through a bunch of different papers to try and work on the paper that we're working on, that there's not really a common definition of when I retreat or why I would retreat or what even characteristics of a non-responder or somebody that loses efficacy over time. And so we had a good discussion recently as a group to kind of decide or propose, I guess is probably a better way of putting it, of some potential vocabulary that we could use to describe these different areas. And I think, so let me kind of lay that out. So a non-responder would basically be somebody that within the first 3 months did not receive an impact. And so I think that's really crucial as we're looking at the studies to kind of say, what percentage of patients does it work on and what percentage of the patients does it not work on? And I think making sure that we give them enough time, even in our clinic, right? So if somebody comes back in a week and their pressure is not any lower, obviously that's too early to decide if it's a responder or a non-responder. But I think at that 3 month mark, I think we all feel pretty comfortable saying that if they still haven't responded at that 3 month mark, that we can clearly classify them as a non-responder. The next definition that we're proposing is kind of early attrition is the word that we use. This is somebody that had that initial response, but then within the first in that first 3 months, but then didn't maintain that response out to 12 months. And then somebody that has maybe a late attrition is somebody that did receive that initial response, and it lasted for at least a year, and then beyond that, they start to lose efficacy. And so obviously these definitions aren't necessarily perfect at this point, but I think it hopefully will give us a common framework that as we're designing studies on one end to kind of say, hey, let's look at our patient population, say, okay, these are my non-responders based on this definition, or these are my patients that had potentially an early attrition that then maybe got a second treatment. What's the response rate in those individuals? And then maybe those late attrition patients. And I think we can all agree that those patients, as we were just discussing, those that have that good initial response and last out to 12 months and beyond are really good candidates to be retreated. Whereas maybe those patients that are non-responders at the beginning, at least the early data that I could say, are probably less likely to get a second response, especially if we keep the same parameters. I think if we increase the parameters, that should increase the likelihood of having a response. But those non-responders are a little bit of a fickle bunch that are probably less likely to receive a response later on. So we're just basically kind of proposing these as kind of common vocabulary so that we can all discuss it amongst ourselves, and hopefully it'll disseminate out into the research.
Thanks, Jacob. So we'll have Mike, as we switch to the second part here, we'll have Mike Javingo pop up, share his screen. What percentage of patients in your practice are kind of fall into the, the early attrition rate? So
I would say kind of non-responders, I would say is generally, and it kind of, I'm definitely using higher settings and slower sweep, all the things that we've been discussing over this whole time course. And so I think my success rate has definitely gone up as I've applied, the slower sweep speeds and increasing my duration my total time. And so I think that helps, but I would say kind of non-responders is probably still like somewhere between 10 to 20%. And I think that's pretty common with the data. And I would say usually I'm probably getting more, if I get a good early response, I would say that it's the two camps that people probably end up most in is probably the late attrition and the non-responders. And the people that usually get an impact really usually last for a good amount of time. So that early attrition, I would say, is a smaller population for me. That's kind of my experience.
Good. I think that makes a lot of sense. All right, so the second part here, now we're gonna do a few case presentations, just kind of very real world from a few of our practices. And why don't we have the panel members just like be ready to unmute, and we'll kind of combine this with the discussion in this last half an hour to get more interactive. And if any of the audience would like to send messages in or questions, this is the time to do it. So go ahead and start, Mike, and we'll see what happens.
Awesome. I like a little bit more of a back and forth discussion anyways. So just sitting here staring at a screen's a little harder. So shout something out if you have anything, stop me at will. So this case is a 56-year-old patient of mine that's an African-American descent individual with end-stage glaucoma, open angle, probably of juvenile onset given the age. The patient in his right eye is 20/60, best corrected. Left eye's NLP has been so for a very long time from glaucoma. A former partner of ours did a trabeculectomy in 1998, was doing great. Patient in his only eye, ranged from 9 and 12 off drops, just doing great. This person's been awesome. But as they all end up, the bleb was quite cystic, avascular, and growing more and more, kind of growing onto the cornea. This is our patient's field. You have the 24-2 on the left and the 10-2 on the right. I think that this goes without saying that this is a patient with extremely bad glaucoma. Now, in comes where the problem occurred. Bleb leak was noted mid-2020 with mild hypotony. There was slight choroidals. The patient went down into the 5-6 range. popped up out of the blue. Patient was asymptomatic, didn't really notice it. It was just on exam. I tried an autologous blood injection, which I know has fallen out of favor with a lot of people, but I've had some decent success with this, and I think it's a pretty low risk procedure, but didn't work. The physician who did the trabeculectomy, she tried a bleb suturing in the minor room to just kind of isolate the area of leakage, but these can be pretty challenging given the cystic nature, and they're very hard to suture for anybody who's tried. Didn't work. So I took the patient back to the OR for a full bleb revision in the operating room, resutured the flap, advanced the conjunctiva, and basically excised all of the avascular conjunctiva. That was great, but he was cytal negative, and now pressure goes up. Tried suture lysis, digital ocular massage, bleb needling, no success, medications added. Eventually, we're 6-9 months down the road, and the patient's pressure is 23 on 4 medications, which is clearly unacceptable given the patient's field. Decision was made to perform MicroPulse. This was the field questionable progression, although over this time course, some of the field defects are a little less dense, but some are more dense. So hard to tell, and we just don't want to lose fixation in this patient. So something clearly needs to be done. As we talked about earlier, I talked about multiple people have in a patient, we're currently recommending the 2,500, 80 seconds per hemisphere, 20-second sweeps. But in this patient who had been completely MP TLT naive, I decided that we just really couldn't mess around. We had to get a low pressure. So the 20 to 25% increase in one of the parameters, I picked time, which I know Tomas said earlier was his first go-to and has been mine recently. So 80 seconds to 100 seconds is a 25% increase in the overall treatment time. So 5 sweeps per hemisphere, totaling 100 seconds, 200 per hemisphere at 200 seconds total, 2,500 milliwatts. And just to, we don't really mention it much, but keeping the duty cycle standardized at 31.3%. I did treat over the trabeculectomy site, which is, I think for the most part, everyone here has been in pretty much agreement when the blood looks failed, low lying, it's important to still treat over the area to get as much treatment area as you can possibly get. Post-op day 1, a little bit of cell, but doing well. Pressure was 18. Pre-op vision was 2060, is actually 2050 now. But 18 pressure on nothing. Post-op week 1, vision. I returned him to all 4 drops. This was a bit of a discussion, and I do think that I'm a little bit more conservative about restarting drops than some of the other panel members. Some people would suggest going to 1 or 2 drops at this point in time instead of all 4. It's just, this is a patient that is typically scary because, as I said, he can drop from 20/50 to count fingers pretty easily if that field changes. Whether or not he would have still been 11 on 1 drop, 2 drops, 3 drops, I don't think is all that clear. But we've gone all the way out to 2 months now, and he's still riding in the 11 range. Vision's excellent. He is on 4 drops. There wasn't any decrease overall in the drop requirement, but patient's doing extremely well. And hopefully we end up in that 12, 24 month range and just keep going further and further out with him. That's that. Nobody shot any questions out. Oh, well.
Yeah. Does anybody feel sorry for Mike?
This is
I think we all live. I think that's our everyday life. No, I think it's like, I'm kind of with you a little bit on a patient like this that's on 4 medications. I kind of talk to the patient if there's one of those drops that they absolutely hate and it's just destroying their life and their ocular surface, then I would kind of take it away. But in a monocular patient that's doing good, that's not complaining, I think I'd agree with you as far as keeping him on the 4 drops. Just to it's a lot, but at the same time, if he's happy, and a lot of times they're afraid to go off those medications like that extra drop. So I think it's a perfect case. And I agree with you on the parameters as far as what you did. And I think, you know, it's a tough situation, obviously, that you were in, but patient seems to be doing great.
Yeah. Thank
you. Mike, I'll throw out one scenario for this patient. Yeah. What would you do if the patient had been on Diamox and did not tolerate it well?
So I'm very good question. And I think a lot of us, as we've discussed before, are really more prone to take them off the Diamox. So if he was doing well, yeah, I would. At
what point would you feel comfortable stopping the Diamox?
I stop it right away. So like on that post-op day 1, if he was previously on Diamox, I would restart all the pressure drops and see where he goes to off the Diamox at week 1 and follow him closely. Whether or not the patient is tolerating the Diamox, for me personally, I like to do everything I can to get them off of it. I don't like ordering, electrolyte panels and seeing if there's any creatinine issues. And a lot of my patients have renal issues on top of what's going on. So if I'm using Diamox, it's a there's a short term to an actual, real plan. Right. I try to always take them off.
I actually in real advanced patients like this, I try to taper their Diamox. I find that it makes me feel safer and the patient feels safer, and it gets them to feel like they're making progress. So, if they're on 250 QID, I'll go to 250 BID or even to 125, BID or TID, and then it makes us feel more comfortable tapering it off. So.
Actually, Brian, what you're saying, when I train in the US, usually it was like an on or off type of thing. Diamox, you would just put them on full dose or you would just stop. And then when I came to Argentina, I saw that people were actually tapering it. I thought, well, if you're just giving them 1 pill a day, you have no effect. And then when I started tapering my patients, I saw that there was actually less of an effect, but you still had an effect. So I tend to also just, play with the dose and taper it if necessary. And, when I'm trying to get them off too.
Yeah.
Okay. So my patient doesn't have as long a history in the practice. It's one of these who just kind of showed up with high pressures and decreased vision. And he had some cataracts. So, took out the cataracts, did, MIG surgery, got him started on some drops. And so with marginal control. So eye drops, we put them on a couple, gave, this is all very fast moving over the course of weeks. So came in high pressures, let's get you on some drops, but let's plan on doing surgery. He did have cataracts. And my position is, I like I think glaucoma surgery works much better with the natural lens out of the eye if it is cataractus, because most of the things we probably do does make it worse. So we kind of moved him through that part of the treatment algorithm. So he got on drops, just some stabilization, but not really like a really, great effect. Let me see. I don't know why my thing's not advancing. So first we did canal cataract. This is my standard thing to do. I do Omni and Hydrus along with cataract surgery. His better eye, it actually worked. He got 20/20 acuity. His pressure was 16 with just Timolol with no meds. His other eye did the exact same thing. His vision was still 20/40, so his vision loss is largely from the glaucoma. He has a central island, not dissimilar from the case that Mike just showed. Pressure 26, so pretty much not outright success on that. Did a Zen a few weeks later. That lasted for about 6 weeks, and his pressure was back at 26. Did an Ahmed valve, got marginal success. Got him down to 20. So once again, this guy had a lot of surgery over the few months. And then we had to keep thinking about what else there is to do. And maybe I wouldn't always save it for last, but we did all the very reasonable things in very short order. And then we did MicroPulse. So he'd had some effect from the Ahmed. That was probably the thing that worked the best. And then we did MicroPulse. And here's his treatment. So the settings I use, so in this case, I tend to slow the sweep speed. So here, this is a 30-second sweep speed. In the past, I used to just have my nurse count every 10 seconds, like you hear, or maybe you don't hear in the video. And it's actually pretty hard to sweep, that slowly, 30-second sweeps. Now with the newer panel, there's kind of the machine will do it more for us. But back in the day, it was a little bit hard to hear it. But my nurse is very good, and she has this nice kind of like Jamaican voice. So it's actually very soothing and it keeps us on track.
40 seconds.
So we did 30-second sweeps. I don't use a speculum. I usually put lidocaine gel and apply, you know, additional BSS as we need to. But I'd say this is a very typical, you know, unedited. I didn't cherry pick the best parts of the treatment. You can see the probe. There's a little bit of conjunctival movement. And I think this gets at, you know, some of the points in terms of probe positioning. It's sometimes very difficult to know where the limbus is. And I think the takeaway point from what we said earlier, you know, at the limbus or a little behind, because I think it varies depending where you are on the eye, how easy it is to locate the limbus. But the whole point is you're not in the iris plane. So we just did the one hemisphere here, and then we'll basically start and do the second one. So I'd say it's a very, you know, typical treatment, but we did the parameter I changed was to slow down the sweep speed instead of increasing the total time increased by 10 seconds. So a little incremental bump up. So in this case, I did a block. This patient was one of these anxious patients. So I have a very low threshold for administering a block, and he did fine, didn't remember the surgery. It was all good. So our right eye is stable at, we put him on Timolol, both eyes, pressures in the mid-teens. So this, you know, made a significant difference. We kind of kept him from being a multiple therapy, you know, eye drop patient right off the bat. He may need additional therapy. This is about a month or so out. I was 6 months out at this one. He's had a little creep, but no change in his parameters. So we'll see. He certainly might need to have a lower pressure, but we dropped him from 40 to 16 in the course of 6 months with a lot of therapy. So that's my case. Tomas, what do you think?
I'm ready to present my case.
I had a quick question. Actually, it's related to both of those cases. So we have seen, you know, in our study, we have seen in probably maybe 30 to 40% of very advanced patients that they get some decrease in vision. Both of those cases, I did not have any. But have you guys seen, and I'm not sure of the explanation. So we've seen in some selected patients, decrease of vision, not to a severe extent, but maybe 1 or 2 lines, you know, up to 3 lines of vision. So I was just curious as to the rest of the panel, if you've seen those and what do you attribute it to? And these are patients that do not have any, you know, CME or any demonstrable reason for the decrease in vision. You know,
Brian, I can actually point out from experience and from the literature, right? You know, when it comes to the literature, when I reviewed it, you could see that most papers were really not looking specifically at, you know, slight changes on visual acuity. And until I saw this study by Varikuti from Sandra Saminsky and Dorarash's group, where they evaluated changes in visual acuity specifically with a MicroPulse. And they did MicroPulse on maybe like 40 patients, and they saw 10 patients, like a 20% of cases that had a reduction in 2 lines, at least 2 lines of visual acuity. And when I saw that, I was like, oh, you know, this is significant. And these guys were really looking at trying to find those changes. But when they actually dissected the cases, so this was 10 patients, right, that had decrease in vision, and 4 of them had cataract progression. And when they removed the cataract, the patients regained the vision. So you have like a 40% out of that group with the original probe, okay? And I think, Rob, we have to discuss a little bit more the difference between the original probe and the new probe. Yeah. But with the original probe, like 40% of those patients just had cataract progression over a year, which could also be just the natural process, right? Then one case had a little bit more inflammation, and that actually, when it resolved, that vision was regained. So that was also something that didn't last. And then you had a patient who I think had diabetes and had CME prior to the procedure and developed CME after the procedure. So this was a guy whose likelihood of having CME was actually higher. And I think they ended up saying that 2 patients did have a decrease in vision, but those were also patients with advanced disease who may have actually progressed, right? So from those 40 patients, really like a few had visual acuity loss that didn't get better. That may have been because of the glaucoma or may have been because of the laser. We don't know, right? But recently, you know, this is about like the new probe and the old probe, right? I mean, the consensus, I mean, all of us, when we discussed this at length, we concluded that because of the organometric changes that were done on the new probe, the treatment is more posterior and more consistent. And what do we mean by that? That, you know, when we were using the original probe, it was a little bit difficult to keep the plane. And sometimes we were just moving the probe around and may have been actually hitting with the cloud of photons, the anterior part of the eye, which could have translated into cataract progression, into more inflammation, iritis, difficulty with accommodation, mydriasis, all causes of decrease in vision. And Cyril actually just presented a poster in this last American Glaucoma Society meeting, which was the first report on a prospective study with MicroPulse TLT and the new probe in patients with glaucoma. And his settings were actually, you know, not that far from our recommended settings, maybe a little bit less. And the safety profile was actually pretty high. And I think he only had like 2 cases of some decreased vision out of, I don't recall exactly if it was, again, like 40 patients, but with the new probe, his prevalence of side effects was so much less. And, you know, this is what my thoughts were for your question.
Yeah. Well, yeah, I think it's critical to, when you're evaluating the literature, to differentiate between new probe and old probe, because as you said, the safety profile is different, I think, as well. The other thing to keep in mind is, you know, if you're talking about more advanced patients having, you know, 2 lines of decreased vision, you know, and a certain percent of patients having that, you have to also take it in context of what are the risks of other procedures that these patients are undergoing. So the risk of decreased vision is much higher with trabeculectomy, with tube shunt, with, you know, with these other procedures that these patients have already undergone or may undergo. If they, you know, say you have a patient with a tube and you're talking about the risk of the second tube, and the risk of decreased vision is probably significantly greater than what we're seeing with the new probe. So.
Yeah, and maybe one more thing, you know, when it comes to the old literature with original probe, is as much as they would describe percentage of patients with decreased vision because of, you know, several reasons, they would also describe a significant percentage of patients who actually had their vision improved after the procedure, most likely related to the decrease in intraocular pressure, right? So hopefully, you know, future prospective, very well-designed studies with a new probe will help us really determine what that percentage is and what the cost is for it if it still remains, right?
Good. All right, you want to do your case now?
Yeah.
That's our last case, right? And then we'll discuss some things, right?
Yeah. All right, so here I wanted to point out at MicroPulse TLT being a good complement for other surgical procedures. And this is a patient that showed up in my practice, 68-year-old female with diabetes, who had bilateral neovascular glaucoma that was not controlled with maximal medical therapy. She showed up like in September of last year, And here you can see the angle of the eye. You can see that it's zip closed 360 degrees. So this is a stage 4 neovascular glaucoma, where there is really no outflow system, at least no conventional outflow system. And you can see the red, I mean, this is bilateral, both eyes, and you can see how much damage she has because of the diabetes in the back of the eye, right? Her visual acuity was actually not that bad. Her vision was 20/20 in the right eye and 20/30 in the left eye. She was already pseudophakic, surgery performed by another surgeon in the past. And her pressure was 60 in the right eye and 70 in the left eye. And of course, I had to intervene as soon as possible. So within a week, this is actually her visual fields. Within a week, she got placement of AMIT valves in both eyes, anti-VEGF, and just a few weeks after, she started PRP treatment. And I would like to also discuss, once I'm done with this, why I did not choose MicroPulse TLT for this right away, for this as a primary procedure for this specific case. But over follow-up, which was 2 to 3 months, her pressure decreased from 60 in the right eye and 70 in the left eye to a range of 36 to 26 in the right eye and 44 to 48 in the left eye, around 2 to 3 months after treatment. Of course, the pressure had fluctuated a lot, but this is the scenario I was encountering 2 to 3 months after placing the valves, also with maximal medical therapy. Her vision at that point in time was 20/30 in the right eye and 20/80 in the left eye. So I decided to do MicroPulse TLT. And in this case, I used for the left eye, which was the eye that was the most affected, I used the consensus setting, but instead of doing 4 sweeps, I did 5 sweeps of 20 seconds per hemisphere. And for the right eye, which was in a little bit better shape, I just used the traditional consensus settings of 4 sweeps of 20 seconds and 2.5 watts with the same duty cycle as usual. And she is now 2 months. I refer her back to the primary physician. I know she's doing well, even though I don't have the most current findings. But at 2 months after the MicroPulse TLT, her pressure had decreased in the right eye from 30-something to 16, and in the left eye from 30 to 40 to 19, with actually less drops than before the MicroPulse TLT, but I kept her on the dorzolamide, the timolol, and the brimonidine. And I added, so this was the regimen for the right eye, and for the left eye, I added a prostaglandin. Maybe next time when I see her, I may actually rearrange the medicines to decrease the number. Her visual acuity remained stable after MicroPulse in the right eye from 20/25 to the same. And in the left eye, it improved from 20/80 to 20/40. And, why did I decide to do first the AMIT valve? I mean, she had a zip closed angle. And I thought that, MicroPulse TLT is my option for those patients who have an AMIT valve that, may have been able to decrease the pressure, but may not have gotten the pressure into target, or when I have to think about a second procedure. I feel that the valve, allows for an outflow, and the MicroPulse will be able to, there are several mechanisms of action, right? But we know that it may have an effect on decreasing the amount of fluid that's being produced in the eye. And I think that both go along very, very well. So this has actually become my routine protocol for this type of patients. It might have been differently if the patient may have had an open angle, so neovascular glaucoma, but stage 1, stage 2, where the pressures were not so crazy high, and I could have, injected anti-VEGF, and then, the neovascular membrane may have actually improved at the level of the angle, then I could have considered MicroPulse TLT as a first option. So this is my case, Rob.
Good. That's excellent. Anybody have any comments on this case?
I think great case. I see them often myself. I totally agree with everything you did, Tomas. You know, in the ones that do have the zipped up angle, yeah, it's challenging for any of the procedures we have. And as we said, neovascular glaucoma is a rough entity to deal with, period. But I think it's good to point out, I think a lot of us use this as an adjunct to tubes that are functioning, but not as well as we really would have liked to. And the other scenario that I personally like to use it is in patients that I really needed to put in a non-valved tube. And it just, the pressure went too high that I just can't sit and watch it for 4 to 6 weeks. It works very well in that situation to, if in the very least, buy you that 4 to 6 weeks worth of time.
Good point. So let's do a few questions here, and then we'll have kind of everyone give a summary discussion. So Ronald, a lot of questions we see coming through. How many times you retreat? What's the most times you've ever retreated, or you think is a good idea?
Depends on your patients. So I think I've got one patient in which I performed 4 treatments in total. But it was a patient with, after every treatment, 1 or 1.5 years of good response. And he was also stable in his visual fields. So in that kind of patients, I feel safe to perform a retreatment. You will always have to look, has a patient a very, what is the rate of progression in a patient? So if a patient has a good response and it holds for a couple of months, I tend to do a retreatment. If you see that the response is gaining away within 3 months, I'm going further to another glaucoma procedure.
Good. What about you, Jella? What do you do? How many?
I have a patient that I've treated 3 or 4 times as well. And it's a patient dependent, you know, if the reason was to really avoid anything else, incisional surgery or CPC, and it's a monocular and you're prioritizing the safety, you know, I don't think there's any limit to how many times you can do it. As long as they respond, there's no problem. And also the attrition rate is not going up. So, you know, I wouldn't necessarily retreat if it only lasts less than 1 year, the treatment effect, or if it doesn't respond at all. But I think, you know, annual treatment, it is reasonable given its safety.
Do you think the first time you treat, Jella, that you're more worried about safety, and like if they got through the first time without really any problems, you feel more comfortable being aggressive?
Yeah, absolutely. If the patient is seen, you know, they have good visual potential, I usually go with 80-second. I used to go actually even lower, 60-second per hemisphere. And then depending on their response, I will select, you know, I'll titrate it up by 20 to 25%.
Mark, do you do anything different?
Actually not. I mean, I haven't treated a lot of patients more than 3 times. Most of them like 1 times only, then some like twice. But in general, considering that we probably not destroying tissue, at least based on the current evidence, you could repeat and repeat and repeat. It's like same, I would say, like you have to discuss with the patient what the patient's expectations are and consider also like other surgeries. But most patients, if they had an initial good response to MicroPulse TLT, they like to have a second treatment.
Yeah, I think that's good. Jacob,
well, I think, yeah, I would just say, I think that initial treatment, sometimes we're a little bit light. Like there was a case that I did just recently that I was really light on the beginning case, and they got a pretty minimal response, but a little bit of a response. But he was just so nervous, had multiple surgeries, and really just almost just convincing him to have anything at all. And so I was definitely on the safe side, like you were saying. Mm-hmm. And he was so safe, and he did so well from a safety standpoint that I felt a lot more comfortable moving towards higher settings with the second treatment. And so I think that I think we're actually learning a lot more as far as what's an acceptable amount of treatment. That paradigm of what we used to do with the CBC compared to this, I think it's a completely different world. And the safety is so much higher that we can kind of push the envelope maybe a little bit more and get really good responses. So that's pretty encouraging to me. But I agree. I think if you don't get an initial response, maybe I would try another time based on the settings or based on the situation. And if it doesn't work the second time with increased parameters, I probably wouldn't do it again. But if they have a good initial response that lasts, maybe even less than a year, I think if I was maybe light on my settings, I'd probably do a second one at a higher setting. And then, but if they last a year, I think, again, I think I make the analogy, it's kind of like SLT. We're used to saying, hey, if it lasts for a year, I can repeat it and repeat it and repeat it. And we don't have the data on that yet, but I think at this point, it seems pretty safe that repeat treatment's not a bad thing.
But it's important to highlight that we are not comparing this with SLT. We're talking about different creatures.
No,
right?
and yeah, no. So definitely, I'm kind of just from a language discussion, and as far as the way that I talk to patients about SLT can sometimes be a similar way that I would talk about it in this case, where it's like, hey, if it lasts for this amount of time, I think we can repeat it. Again, yeah, I completely agree. It's not in that same realm as SLT, obviously, but I think the discussion or the framework and the mindset is maybe a little bit similar as far as duration and retreatment.
And when it comes, like, if I may, when it comes to like how many times we have repeated treatment as a panel, it looks like 2, 3 to 4 times has been our experience, and so far we have not had any bad experiences with that when it comes to side effects, hypotony. Everyone would agree with that based on.
Yep. Good. All right, Brian Francis, what do you think the timeline is typical for IOP reduction? Like, what do you expect? Do you have late responders, or what do you do if it's not so great at first? How long do you give it?
So I expect a response at 1 month. I usually tell the patients, whatever your response is at 1 month is a very good indicator of what it's going to be longer term. But, in some patients, I'll wait up to 3 months, if they're don't have a compelling reason, very advanced stage, et cetera, to move on to another surgery. So.
Okay. Brian Jerkins, what's your experience in your population?
I normally see my patients back at the 1 week mark, and I do normally expect to see some improvement at a week, but I agree with Dr. Francis. At 1 month is where I really am starting to draw the line of, am I seeing a responder or not? Sometimes if there's a little bit of minimal inflammation or a little confusion on their previous medication, at the 1 week mark, I may not see much change, but at 1 month is where I really kind of get a good idea, is this going to work or not? And if it's not getting a great response, that's where, kind of going back to the last point, you start bringing up the option potentially of an enhancement or a retreatment down the line if they've had a good experience.
Mike Javinga, you think any different in your population?
I very much agree. I see them 1 day, 1 week, and 1 month. The earlier appointments are probably unnecessary. It's extremely rare that at 1 day and 1 week, their pressure isn't very well controlled on almost every patient. The month one is really just a very telling visit that it helps me decide where I'm going with it. You can, as people have said, people wait all the way out to 3 months, but at 1 month, you start having a discussion of, this is looking good, or we may need to start discussing other options. My patients, generally, I have completely off of steroids for 3 weeks at that point in time. So that's another important point. If you're running the steroids all the way out to a month, I wouldn't make too much decisions one way or the other based upon a patient who is either on steroids or recently stopped them.
So that said, how long do you do the steroid for?
I just do a week, actually 6 days. I do TID 2 days, BID 2 days, and Q day. I want them off steroids completely by my week 1. And once I went to that, I have happier patients. I honestly haven't seen anybody who really had a big problem inflammation wise because of a quick taper.
Do you put them on a cycloplegic?
No, that I at the beginning, I atropinized everybody, especially the younger patients are grumpy about it. Nobody likes it, photophobia, accommodation issues, etc. It took me a little bit, but meetings, things like what we've done, I've heard a lot of people going away from it, and I finally just pulled the trigger on it. And I have not seen any issues from stopping atropine or cycloplegics in general. And I don't have, I really have had no problems whatsoever. I still atropinize continuous wave CPC patients, which I'm assuming most people do, just increased inflammation in general. But these, I don't really see any reason to atropinize them or cycloplegia in general.
Mark, what's the natural course of IOP in your case, in post-op course? What's the natural post-op course?
So we actually looked at the post-op course, and most patients, same as everybody said before, like had a reaction like that the IOP was going down after 1 week. I agree also, like after 1 month, you can usually judge, but it really depends how long you give the steroids. I usually stop after a week as well, but if colleagues give the steroids for a month, I would not be afraid to wait a little bit longer than 1 month to judge completely what the result is. The discussion with the atropine, I just want to add, we really have to be aware that first of all, we see less inflammation compared to traditional G-probe CPC. And it is a different treatment, and therefore we can't expect the same inflammation, and we don't need so much atropine. It's also, we looked at patients' pain levels. And pain levels after the procedure, we didn't look prior to 1 hour, but at 1 hour, they were back to baseline. So they maybe slightly increase immediately after the procedure, but if you ask the patient after 1 hour, they're back to baseline. And considering that, I also agree, like atropine is definitely not necessary anymore. And it's a different procedure from the G-probe, so we have to make different treatments afterwards.
Yeah, those are excellent points. And I think that's, you know, I think everybody, does anybody feel any different? Want to add anything on before we need to move to the next question?
Yeah, just to reinforce what Mark just said, right? I mean, as a consensus for most of our cases, we think that there is almost no post-op pain, very little inflammation, and there is no need for cycloplegics. I mean, that's for most of the cases. You could have exceptions, but that's what we all do by now, right?
Yes.
Yeah, one of the questions in the chat was asking about subconj steroid. I'm not using that as anybody else. Yeah, so I think that kind of getting back to just the minimal amount of steroids that we need. And I would hate to, again, if you have a subconj injection, the steroid response for that can last for months. So I think we all probably on the same page as far as minimal steroid treatment. And now I used to be at a month or 6 weeks, and now I'm maybe not down to a week, but I'm at 2 weeks with steroids, and I feel pretty comfortable tapering pretty quickly.
Yeah, that's the takeaway point. It's probably counterproductive. Yeah, sub-T non-steroids is better counterproductive. Ronald, do you combine this with any other procedures at the same time, like cataract surgery or other glaucoma surgeries?
No.
And we're done.
I performed cataract surgery and Iridex laser treatment in, I think, 2 patients, but I don't combine them very often. So I don't know if everyone, another lid in the panel does combine those 2 a lot, but I have not a lot of experience with the combined procedure.
Jella, what do you do?
I do not. You know, okay. Most of the patients that I treat are the ones who I'm trying to save them from incisional surgery to begin with. And if I'm doing incisional surgery, I'm probably going to do either angle surgery or subconj filtering procedure.
Yeah, I'm with you. Does anybody combine it with anything?
No, I've done a few combined and just really honestly didn't have it was the safety profile, and at least in my experience, is significantly worse. Both procedures, you're adding inflammation, but you know, to preface that, I'm also somebody who likes avoiding combo procedures, but, you know, this MIGS aside, you know, I try not to do phaco tubes, phaco trabs. I just think that in general, all of these procedures that we have do not work as well if we're putting this significant inflammation from a cataract surgery in at the same time, and our side effect profile significantly worsens. So I'd recommend against it.
Yeah, no, I think we're all on the same page, and I agree. It certainly doesn't help if you want a good cataract surgery result. It doesn't help that, and at the same time, like Jella said, the best thing about this is we're not doing an incision stuff, so people can. I've had people go back to work the next day after this if they are go-getters. You know,
there was even somebody who mentioned in the question and answer, you know, saying that they were seeing zonular laxity during it. I mean, again, it just adds more to each of these. We don't know. I had a significant inflammation case after one of these. You know, does it do zonules, et cetera? We don't really know, but I just don't see many reasons that we would need to add these two procedures in at the same time and give that patient maybe a suboptimal outcome.
Yeah. So Brian Jerkins, can you just clarify about the probe placement thing with this and how this differs from the old probe, like how where you put the probe exactly?
Well, I think this probe placement's actually a little bit easier. As we mentioned the dog ears previously, I'm placing this just about 1 millimeter behind the limbus. As the previous probes, being a little bit bulkier, tended to sit just a little bit more on top of the limbus in my experience. And it was also a little bit harder to see the probe. With this one, I actually look for the probe light, which I don't think was mentioned a whole lot, but for me, that's actually a good little marker to follow, seeing that 2 to 3 millimeter posterior of the limbus. So that's actually how I teach my residents to try to actually see the probe light especially under some lidocaine or your coupling agent. It's actually very easy to see.
Yeah. So up north, we call them bunny ears, not dog ears. Anyway, Jella, what do you do for probe placement? Do you think it's a lot different with this probe? Just to reinforce this, just to make sure. I think it's one of the more important things we talk about.
Yeah, so with the revised probe, I actually put the bunny ear right at the limbus. I used to put it 1 millimeter posterior to the limbus with the original probe. It was because it was shorter and it was much harder to keep it posteriorly. And I think we kind of talked about this, and it's better to be more posterior than anterior for MicroPulse.
Brian Francis, anything to add on that probe placement?
No, I just, with the new probe, I place it right at the limbus. With the old probe, I was cheating a little bit posteriorly, just because, you know, to try to get that more posterior energy placement.
Okay.
Yeah, when we speak about that 0 to 1 millimeter posterior, is that sometimes the limbus is also not so easy to define exactly where it is, right? So if we want to error, you know, if we go a little bit behind, I mean, that's fine. So that's the reason why we're talking about the 0 to 1%. But within the consensus panel, I mean, 50% would put it right at the limbus and 50% a little bit more posterior. Okay. There was more need for that, right, with the first, with the original probe than what it is now for the revised one.
Mm-hmm. So Ronald, is there any types of glaucoma you don't use this in?
You have to be a little bit cautious in heavy uveitis eyes, but any other type of glaucoma I can use it if necessary.
Mark, do you have any don't go there's?
I'm kind of the same. I mean, for uveitis, it would be my first pick. If I really think about doing a laser in uveitis, I would feel more comfortable doing MicroPulse compared to G-probe. Mm-hmm. But in general, you can use it in other eyes as well. I mean, all different kinds of glaucomas.
Jacob, do you do anything different? Or what?
Yeah, I mean, I think we kind of talked about it a little bit with the neovascular. Like if I have an angle that's zipped up, I usually like the idea of having some kind of outflow. If they have no outflow naturally, I like to put a tube in first and then supplement with this. Because I in my mind, I'm thinking that if their angle is completely closed, I have to basically decrease aqueous production to like a perfect level because nothing's going out really. And so, so I like the idea of having a tube in there first in the neovascular cases. Other than that, I agree with everything everybody else said.
All right, well, just let's to wrap this up. Let's hear, okay, let's ask 2 questions to everybody on the panel. So the first thing is what's the best advice you'd give to like a starting surgeon, like a resident? I think most of us teach like novice surgeons. And what do you think like the best thing is that you've changed or learned like along the way in the few years that you've been doing this? Because we're all we've already been on a little bit of a journey with this. So who wants to start?
I can start, Rob.
Tomas, of course. Let's hear from you.
Well, given that we spent like almost a year working on this consensus and we've done a very in-depth search of the literature and this Delphi process, my first answer would be just to whoever wants to start doing MicroPulse is just to see both webinars, you know, the one that we gave last year and this one. And we submitted already for publication the paper from last webinar. And we will hopefully submit this one the next month. So hopefully when the papers get published, just for people to read them as we think it's a foundation, right? It's a starting point just to put in order everything that was done before and to hopefully help what will be done next.
Ronald, what do you think?
I think if people want to start with the MicroPulse treatment, especially if you use the standardized settings we already discussed in the previous part, it's very safe to start with. You don't see a lot of complications, of no complications at all. And yeah, it's when you start to use it, you notice that you can use it in a lot of glaucoma patients. It's various stages, various types. So yeah, when you start, it's very safe procedure to learn and to perform.
Brian Francis?
So I'll throw 2 observations in there. I think the first one is to come in without preconceptions. So if you've done continuous wave in the past, if you've done a lot of ECP in the past, this is a different procedure. So it's performed differently. The safety profile is different, you know, so think of it as a different procedure and don't come in with preconceived notions of what patients might, you know, how patients would respond, how much inflammation you're going to get, et cetera, based on those other iterations of cyclophotocoagulation. The second one is if you are kind of on the fence of you know, what patients to start off with. I think some of my happiest patients are patients that it's been discussed previously, but a patient that has a tube that's functional, but the pressure is not that good. This is a great option. It's non-incisional. You're not putting in a second tube and running all those risks of exposure and strabismus and et cetera, et cetera. So that's a really nice patient population to start with to get good results.
Good, excellent. Mark?
Well, not much to add. I think the most things I learned during this process of the last year was like the importance really of the coupling agents and the sweep velocity. If you start doing it, sweep velocity of 20 seconds per sweep is really hard to keep because it's very, very slow, and you think you're going slow. Really keep the timer in mind. It is probably not slow enough, but it makes a huge effect on the results. And the same as Brian just said, like my happiest patients are also the patients after a tube, whether it's in the high teens, need the low teens, and I'm more than happy to get that than a big surgery again.
Yeah, I agree. Jacob?
I agree with basically everything that's been said, but I think to echo Brian, and that's a completely different procedure. And I think the big thing that I've learned in this process is, one, to be more consistent as far as, you know, sometimes it's just like, well, these are the numbers, just sweep back and forth. And, you know, I think we have to be a little bit more diligent about how we do the therapy, where we're placing it, the coupling agents, the speed, all that kind of stuff, I think is really crucial to really be more meticulous about it rather than just kind of, I got this, I'll just do whatever I do, right? I think by being meticulous, we're gonna have better results. And then I think the second thing is, I think we're really just scratching the surface still on this technology as far as what its potential is. We're so, I think we're coming from a world of continuous wave to MicroPulse. And then I think even moving towards the new probe made a huge difference as well. And almost as big of a difference as going from CBC to the old probe, from the old probe to the new probe, in that we're finding that we're getting much less inflammation, we're getting good results and less side effects. And so I think, with time, I think it's really changing into something that's so safe that it's being used earlier and earlier on our patients. And I think that's the thing that I've kind of learned. And I'm excited for kind of the future as we kind of get more studies in safety and efficacy to see where the, we've talked a lot about some recalcitrant cases today, but I think it's also has a big place in the non kind of severe glaucomas. And, I think we're still stuck in that world of CBC, but I think with time, as we slowly inch forward, we'll see that it's going to be more effective in kind of those more mild cases. So we'll see what the future holds with that.
Excellent. Brian Jerkins?
I would kind of reiterate everybody else's same comments as far as what I've learned from this. Is I've been doing this for several years, and now with the newer probe, the focus is slowing down in technique. And the more you slow down and focus on technique, the more reproducible outcomes that I'm seeing in my patients. As far as somebody starting out, is realistic expectations of what this can do. This is a different type of laser than we're used to, and it's a different type of surgery than what you might get with a trab or a tube as far as expectations of lowering drops. But with this, we can get very good, safe outcomes. That is, in our patient's journey of glaucoma, a really great bridge or even a continuing treatment to maintain their vision. And I would second Jacob that this is a great alternative to some of our patients who have that moderate disease and don't tolerate drops, but you don't really want to take them to that next step of incisional surgery. This can give them a very good option of decreasing their drop burden without going through major glaucoma surgery.
Yeah. Good points. Jella?
Yeah, I think we've all learned how critically important the proper setting and technique it is for the safety and effectivity of this laser. So, that being said, there's a lot of literature out there. Some are good, some are bad, but I feel like we should really look at them with, as a grain of salt, because most of them were done with the original probe, with a variable energy setting, with the unknown techniques. So we almost need a, refresh and properly design the studies where we can really show what this laser can do. In my experience, it's extremely safe and very effective, with the proper dosage, and it's helped hundreds of my patients. So I know a number of people are still skeptical or not sure whether they want to dip their toes into it, but I think with the proper setting, we can really help a lot of patients.
Mike?
So the current settings, I think, are an excellent starting point, but as multiple people have said that, I think that they're extremely safe. And in discussing with all of you, it's blatantly obvious that, we can even go more than what our settings are currently at. It's taken us a long time to get to where we currently are at. I was one of the first to use this in the pre-release, and I think we're at 2,000 milliwatts, 50 seconds per hemisphere, 10-second sweep times. And we have, as a group, as a whole, putting our minds together, have augmented what we're doing to get to this point. And I think we're at a very good starting point, but we can even push the envelope more. The other thing is, just for the people watching, that this isn't a magic bullet. There's no magic bullets in all of glaucoma. Otherwise, we would be just saying there's one procedure that everybody should have. It's very good in pre-surgical. It's very a good adjunct after surgery. Most of the things that we do, take up maybe 20% or 30% of the patient's pressure needs. So it's just an excellent tool to have in all different types of glaucoma, all different surgical states. And I think it's absolutely necessary in today's glaucoma world.
Yeah, I think those are great comments. And I would just add for myself, I think the biggest thing is there's no shame in retreatment. I think if you had a safe, first treatment and you need a little bit more, you're advancing the settings. Because as we discussed earlier, the recommended settings is, I do believe everyone should start with that, but there's room beyond that too. So it's always better to start and be safe. And I've learned to be more consistent and compulsive in this technique as well. It's not just a 3-minute technique, it is, but the attention to detail, I think, does make a difference. And slowing the sweep speed is very, as was said earlier, is very hard to do. But I think it does make a difference. So with that said, to respect everyone's time, I want to thank everybody for being here. This is all recorded and available online. The two little, the websites are here for the prior version. If you want information off that, you can just pluck individual sessions to obtain the information you want to get at. Both in this session and the prior session. And thank you all for being here. Bye, everybody.
Thanks a lot.
Have a good one. Take care, guys.
Bye.
Have a great afternoon.
Bye.
Thanks for coming.